I'm Tudor Oman. I'm one of the Paediatric Emergency Medicine consultants in the Royal Belfast Hospital for Sick Children. And I have been given the task of talking to you about the initial management of coma. Now, there's a bit of overlap through the day. There's going to be a talk about traumatic brain injury at a later date. So my initial presentation is going to be about the assessment of a child coming in with a markedly decreased level of consciousness. I do have a warning, is that I've been playing around with AI imaging, and so a lot of the images that you'll see generated here have been artificially generated, and I thought after a while just sharing the weirdness with you was the way to go. So, coma. Initially, let's look at what consciousness is. So consciousness is a combination of arousal, which is wakefulness or alertness, and awareness. Arousal being the physiological state of wakefulness, and alertness. And this denotes your consciousness in combination with the content of consciousness, such as attention, language, memory, visual, spatial skills, and these together create the capacity of awareness. Awareness is that subjective experience that you get on interacting with environmental stimuli. You can be awake, so you can have your arousal and not have awareness, and not necessarily the other way around. We have a look at the anatomical structures that are involved. We have arousal being a midbrain or a ascending reticular activation system bundle of nerves that interact with mainly the thalamus and hypothalamus, and then the cortex to some degree as well. Awareness is a more loosely connected bunch of nerve fibers that are in the cortexes and the subcortical structures. Knowing this, to me, all it does is it gives us an idea of, well, if this is where these nerve bundles are, then we can figure out, well, what actually causes a decreased level of consciousness. So because you've got the midbrain affected, you can have problems in the midbrain or in the brainstem are going to cause a decreased level of consciousness. We're going to have anything that affects the cerebral cortexes bilaterally is going to cause a reduced level of consciousness as well. And that's inadequate blood supply, such as in stroke, or inadequate substrate, such as in hypoglycemia. Trauma, toxins, poisons, or intoxication can also cause a reduced level of consciousness as they affect the entire cerebral cortex bilaterally. Unilateral lesions can also be involved as long as they have pressure effect or mass effect causing damage on the opposite side. So as in this image here, you can see a mass causing midline shift and tonsillar herniation. So this is going to cause a decreased level of consciousness, but a unilateral lesion by itself in general doesn't. Loss of consciousness, as we all know, is a continuum. There's different ways of describing it. One that has come up in the literature quite a lot is delirium, confusion, or disorientation, which has some reduction in arousal, but you can process external stimuli, but not necessarily correctly. Lethargy is more moving on to a mild decrease in arousal, but you're still able to respond to verbal and tactile stimuli. Obtundation, decreased arousal, but the response to verbal and tactile stimuli is there, but it may not be appropriate. And then there's stupor, and leading on to coma, which is the most profound state of diminished consciousness and awareness. Now that might sound familiar because when we have a look at how we actually do it in our clinical practice, we use the GCS scale, Glasgow Coma Scale, and this is a guide to assessing someone's level of consciousness through eye movements, opening, best verbal response, and best motor response, with the most profound level of decreased level of consciousness being 3 rather than 0, as I was once handed over by somebody that this child had a GCS of 0. So 3 is the lowest that you can get. This gives us a a way of monitoring a child while we're managing them as well. So repeated Glasgow Coma scales monitors the level of consciousness as we manage the patient, treat them, or if they continue to deteriorate, gives us warning. It doesn't give us any diagnostic clues, but it can give some prognostic factors in certain conditions. In the ED, sometimes we use the AVPU score, alert, responds to voice, responds to pain, or is unresponsive. It's very crude, but gives us an immediate idea of where we are at. A score of P or U gives us a GCS of less than 8. And this is important because when you have a GCS of less than or equal to 8, you have potentially lost your protective airway reflexes, and you need to start to consider whether airway protection is needed. For everybody, a decreased level of consciousness is less than 15. And that is our starting point. So we've talked about the structural of decreased level of consciousness and what might cause it, but in real terms, what are we talking about? Traumatic causes are the most common worldwide, and that can be intentional or accidental. Non-traumatic leading cause is infection. That could be meningitis, encephalitis, abscesses, malaria. You could have metabolic, such as MCAD, which you may get hypoglycemia, or other metabolic conditions in which there are substrates that are floating around that are toxic. Seizures, one of the most common emergency we see in our emergency department, can have profound loss of consciousness as well. Then intracranial causes, hemorrhage or mass lesions, toxins, hypoxic ischemic injury from either prolonged cardiopulmonary resuscitation, drowning, and that actually has the worst prognosis out of them all. And then hypertension leading to hypertensive encephalitis, encephalopathy, which has a good prognosis as long as you manage it well. So there's a number of different causes, and we're going to look at some of those. So the incidence is about 30.8 per 100,000 children under 16 years. Non-traumatic and traumatic are similar numbers, but because non-traumatic is a larger group by itself, it's the most common, higher in the first year of life. Infection, most common non-traumatic, and non-traumatic and non-accidental causes are more frequent in younger children. I thought this was an interesting figure, is that 2/3 of infants had non-specific cause identified for their decreased level of consciousness. So coma is a medical emergency. So, you've got to remember that coma is a symptom rather than a diagnosis. We have a child who has some sort of problem working at them that has reduced their level of consciousness, and we need to identify that. And while we are identifying it, we need to try and make this patient as stable as possible to prevent ongoing damage or secondary brain damage to this patient while we investigate, while we identify the cause. So our aims are to minimize neurological damage, to look for the cause and initiate treatment in a prompt manner. The outcome can be quite vast, so you can recover with appropriate treatment, or some of the causes can just resolve with time. Once removed from a noxious stimulus, for example, they could die, or they could progress to having a more deep state of unconsciousness, such as persistent vegetative states or minimally conscious state. So what I've based this talk about is there's a few guidelines out there talking about how you approach a child with unconsciousness or coma. And I want to talk about the structured approach to these children to try and ensure that while you are investigating this child, you keep this person safe and giving you time to identify the cause. It has to be said that there are a number of aspects to this. Is you've got your primary assessment, your A, B, C, D, E, F, G approach, and that's because I'm a simple A&E doctor. And so A, airway, breathing, circulation, disability, and don't ever forget glucose. But you've also got your observations, you've got your history from the parents that you might get just little bits of, or a rapid assessment on your initial review of the child. And all of these give you little bits of information. And I'd say it's very rarely that we don't get a clue as to what may be going on with this child. It's not just a child lying there with normal observations, no indication of what's gone on. There are things that we can start to consider that would help us go down a diagnostic process. And if not, there's process that we can move on. History is important, and although it's not part of your A, B, C, D initially, just wanted to touch base. So if a child has a known chronic condition, such as a metabolic condition, a seizure condition, a liver problem, these can all give you clues as to maybe what has gone on with this child. The speed of onset can give you clues, such as a sudden onset may indicate an intracranial bleed, seizure, or toxin ingestion, or slow onset may indicate something like a metabolic condition in which there has been gradual buildup of a substrate or drop in the substrate, leading to this coma, space-occupying lesions that are slowly expanding, infection, headaches, vomiting, fever, altering levels of consciousness, change in personality over the time. All of these give you clues and can be sought out in quite a quick format, having a list in your head as to what you may ask the parents. Are there drugs available in the house? Has the child a history of self-harm or drug ingestion? Are there infant deaths in the family or young deaths in the family? And then inconsistency or concerning history from the parents. These all need to be taken into consideration as you approach this child. And the importance I'm saying is that you have all of these aspects, and they don't happen individually. You don't always just do your A, B, C, D, and then ask the questions and then do some treatments. These all happen simultaneously. So airway, we always approach the airway first. And what I'd say is that you don't know what's happened to this patient. This could have been a shaken child. It could have been a traumatic injury. You don't know. It could have, if it was a dive into a pool. Sorry, I should have probably given you the history. 6-year-old boy brought in unconscious by the parents, was previously well, no past medical history, no drug history, found unconscious in bed in the morning, as didn't turn up for breakfast. And that's all the history that we have. So we're going to consider C-spine. Do we need to protect the C-spine? Are there injuries that we don't know are existent? So if you have a high suspicion of non-accidental injury or some other form of trauma, or there's trauma in the history, then maybe C-spine precautions might be good. I've talked about GCS being less than 9 before and the need for airway protection. So if I told you that this, I've added in GCS at the top here because the airway person often does a quick assessment of conscious level when they're assessing the airway. Is the child responding? Are they responding to pain or not? And if they're not responding to pain, that's a quick assessment saying this GCS is very low. Maybe we need to do some airway protection. Okay, I'm going to talk to you about ventilation and the need for the benefits of that in breathing. So airway assessment is essential. At this point, you should also be getting some observations on, and most of the guidelines would state that there should be a minimum data set of your respiratory rate, your saturations, heart rate, blood pressure, conscious level, and temperature taken every hour. In the ED, we have constant monitoring on in an unconscious patient, but I'm aware that these children may be unconscious or in coma for prolonged periods of time, and hourly observations is the bare minimum that should be going on. So in our child here, we're looking at their effective breathing. This is an unconscious patient who is not responding to pain. So the first thing you really want to do is assess whether there are signs of life, or whether this child is actually not in cardiopulmonary arrest. So that needs to take place first. Looking at the effort effectiveness and efficacy of that breathing pattern. If they are breathing, you're going to decide, well, what kind of breathing are they doing? I've got a respiratory rate of 45 breaths per minute for this child. So that's fast for this age group. So why are they breathing fast? Tachypnea can be seen with pain, hypoxia, metabolic acidosis, pontine injuries. If their breathing was slow and irregular, you might be thinking of periodic respirations. Some of the books would say diabetic ketoacidosis, although often I see a child with diabetic ketoacidosis with an increased respiratory rate as they try to blow off their excess acidosis. But deep sighing respirations is classic for that. Metabolic acidosis, as I've said, and then sedatives and intoxication can cause hypoventilation as well. So what I'm saying is there's different clues as to what potential causes are based on the respiratory rate, based on the observation, that we are seeing as we move through the assessment. And these all give us clues towards the end diagnosis. Ventilation I had mentioned. So if you have an unconscious child with an unprotected airway, you're wanting to protect that airway from possible inhalation of foreign body vomit, blood, or anything else, so that it doesn't worsen their respiratory function. Ventilation in unconscious children and ones with potential brain injury have a lot of different benefits to it. Ventilating protects the airway. It allows you to control the level of carbon dioxide within the blood, keeping it within normal levels, 4 to 4.5. This allows maximal cerebral perfusion and prevents secondary brain injury. Hypo or hyperventilation can result in worsening brain injury, secondary brain injury, due to poor cerebral perfusion. And it allows you to also take away the increased work that the heart is doing to maintain normostasis. So it removes some of the metabolic work that the body needs to do and reduces the oxygen requirement that the body has. So ventilation can also then provide an opportunity for putting lines in, doing procedures such as LPs, going to MRI scanners or CT scanners for your further investigations in a safe, planned manner. So in an unconscious child where you're struggling to know what's going on, who's got a markedly reduced level of consciousness, intubation and controlling of that ventilation is a good way of safely proceeding down a number of different investigations. However, you need to complete your A, B, C, D and do a full assessment of their neurology before you paralyze them. So we're getting set up for that in this child now. So our circulation. So in that respiratory, again, I've said that the saturations are normal and the airway, the air sounds are in the chest are clear. There's no added sounds. So this is a child who is unconscious and has good air entry, but is breathing fast. So I'm thinking more along down the lines of a metabolic abnormality or some form of acidosis building up or other structural abnormality. Moving on to circulation, as again I said, we need our heart rate, our blood pressure. We need to do a full set of observations. Tachycardia in this child, 160 beats per minute. This can occur with fever, pain, hypovolemia, cardiomyopathy, arrhythmias, as well as status epilepticus, which is on the list as to what might be going wrong with this child. Bradycardia can be a pre-terminal sign. Is there hypoxia present, leading to bradycardia and then eventually cardiopulmonary arrest? Or is there raised intracranial pressure in which the blood pressure is rising, the heart rate is dropping, and then there's becoming irregular respirations or fast respiration. And that's called Cushing's triad, which we're going to talk briefly about as we go through this. So in this circumstance, we don't think so because the blood pressure is low. So we are dealing with a child with a tachycardia and a low blood pressure for some reason, which brings in the concerns regarding sepsis, hypovolemia due to cardiac causes, arrhythmias, etc., poisoning. Low blood pressure can be a result. Low blood pressure can result in worsening brain injury as well. So in children with unconsciousness with an unknown cause, you're wanting to maintain their blood pressure within normal limits, and you're going to give fluid boluses to these children to maintain a normal blood pressure for their age. If it is due to trauma and it's loss of blood, then you should be replacing that fluid with blood. If it is something, if it is sepsis, then you're going to replace it with fluids, and you're going to move on to inotropes quite quickly if you're concerned about raised intracranial pressure and fluid overloading them. And that's where you're going to get your PICU consultants in to try and manage the inotropic support and ongoing fluid management for a difficult patient. So if there's intracranial concerns, be cautious with the fluid boluses. Hypertension can be due to a number of different things as well: pain, agitation, certain toxidromes such as your sympathomimetics and stimulants, and then raised intracranial pressure leading to your Cushing's triad as well. Investigations you're going to send off at the same time. You're going to send off your blood gas. This is going to give you an idea of whether they're acidotic, what their CO2 and O2 levels are they retaining? Is this metabolic? Is it respiratory? What their lactate is and what their glucose is. And glucose should never be forgotten. And guidelines would say that you should have a glucose done immediately on arrival of an unconscious child, or at least within the first 15 minutes. And this can give you a lot of information in children. High metabolic rates leads to them burning off their sugar significantly. Prolonged starvation doesn't necessarily get managed so well in the younger children. So there's a number of reasons why children who are unwell with high temperatures or just trauma to their body, stress, have low sugars, let alone the metabolic conditions. You're going to check your electrolytes, your liver function, make sure there's no hepatic encephalopathy going on, full blood picture for your white cells, your blood culture for your infections, ammonia for some of the metabolic conditions that can cause coma, and a urine dipstick for infection, but then also importantly for toxicology to ensure that drugs of abuse haven't been taken in this circumstance. So, as I've said, you need to have glucose within 15 minutes of arrival when you're assessing, and this comes into assessing of disability, as it's a common cause for children to have a decreased level of consciousness. We're going to assess our GCS, and we're going to then monitor that along with our observations for any signs of improvement or deterioration. We're going to look at our fundoscopy, looking for papilledema. Pupillary responses can give us clues as to what's going on in the brain and where the lesion may be, or what potential toxins may be involved. Reflexes, motor responses, meningism, stiff neck, for example, need to be considered as a quick assessment of their neurological disability as you go through this. If their blood sugar is low, you're going to immediately give a bolus of dextrose to bring that up, and then recheck that blood sugar within 15 minutes. In the UK, we're currently giving 3 mils per kilogram of 10% dextrose, but that has changed over the years numerous times, from 2 to 5 to 2 now to 3. So whatever your local policy is, you're going to give a bolus of dextrose. You're going to consider neuroprotective measures, which I said we're going to discuss later on. The neuroprotective measures include a 30-degree head-up tilt to allow for reduced drainage of blood from the head, so the blood isn't pooling, like in this kid with his head flopped down. We're going to sedate him, give him some pain relief, stop him moving, reduce his metabolic demand. We're going to make him normotensive, normothermic, normoglycemic, normocarbia, and correct electrolytes and pain relief, and give him pain relief. There are some other factors, such as if you have a cervical collar on him, you may want to loosen that to allow for SVC drainage. I had mentioned Cushing's triad before, the triad of bradycardia, abnormal breathing, and hypertension. If you are seeing this and you have impending herniation, you want to treat this aggressively. Hypertonic saline is the choice that we have in our hospital. We do have mannitol, but we're more used to hypertonic saline, and giving a bolus of this as soon as you are concerned regarding the possibility of raised intracranial pressure. The other treatment is to hyperventilate them for a period of time. Normally, hyperventilation can cause worsening of secondary brain injury, but it is a lifesaver in the in a child who has evidence of potential herniation. So it needs to be considered at that point. Looking at the eyes, we have a number of different responses that we can get. We can get anoscoria, unilateral dilated pupil, which suggests brainstem insults or a supratentorial lesion that is causing compression of the oculomotor nerve or the nucleus within the brainstem. You can get bilateral dilated pupils. Are they fixed? If that is the case, then this could be seen within midbrain injuries, but can also be seen with some sympathomimetics and anticholinergics as well. So just check what they've had prior to making a judgment as to whether they're fixed and dilated. Irregular pupils could be seen in trauma, conjugate gaze deviation and frontal lobe lesions, and small pinpoint pupils could be a pontine injury, or could be metabolic disorders or certain intoxications. Decerbate and decorticate posturing, it comes into your GCS, but can also give indications as to where the lesions are. This is when you give a painful stimulus, the child will perform these postures. What I would say is I see this quite commonly following a prolonged seizure, which often resolves quite quickly afterwards. But if you see these, you have to wonder whether there is something else going on. So decerbate posturing includes the extension and internal rotation of the arms and legs. Decerbate posturing implies brainstem involvement and is the worst prognosis. Decorticate, considered not so severe, but you get flexion of the elbows and wrists, and this can imply potential injury to the cervical spine tract or cerebral hemispheres. Moving on to exposure, it's important to do temperature. We're talking about a potential cause of infection, which is most likely in children. And in high temperature, you can have that due to infection, but you've got to remember it can also be due to inflammatory processes, as well as prolonged status epilepticus, neuroleptic malignant syndrome, hyperthyroidism, and also anticholinergic poisoning. If at all, even with a normal temperature, you are concerned that sepsis is a potential for this child, and I can tell you now that if I had an unconscious child with an unknown cause that I was struggling to find a diagnosis for, I'd be doing empirical antibiotic coverage until I knew otherwise. So if you're in doubt, start antibiotics. Hypothermia can also be due to infection, but is more likely to be environmental. So if you have a trauma that's been lying out for a while, or a drowned patient, or you have hypothyroidism or drug ingestion, those are more likely to cause hypothermia. Severe hypothermia may be contributing to a reduced level of consciousness, and so consider that and warm the patients back up to normothermic. Exposure is vital in children. Without exposure, you're going to miss the rashes such as petechiae, purpura. You're going to miss the cherry red spots of carbon monoxide poisoning. You are going to miss the signs of abuse or injury. And although we don't like to think about it, we have to in pediatrics. It is part of our job to assess this child, check that the history is consistent, that there are no concerns regarding a non-accidental injury. And I cannot tell you how many times I've been resuscitating an unconscious child only for the parent to tell me something, and that makes me go, oh, I need to consider non-accidental injury. And unfortunately, too many times it is actually the case. So exposure is very important. Any child who is unable to communicate with you when you're assessing them, you need to have a look at their body to ensure that you're not missing anything. Further investigations are obviously neuroimaging. CT modality is the first choice initially, because you can get it quickly. It doesn't take as long as an MRI. And when you've got an unstable patient, you're still trying to stabilize. CT is what you can choose. It also allows for repeated imaging over time. MRI gives you more specific structural information and more prognostic information, but takes a little bit more planning. ECG is vital. This could be an arrhythmia. It could have been a seizure, but you're looking for structure, you're looking for rhythm on this. Lumbar puncture is key, but you need to be careful with lumbar puncture in an unconscious child. So if there are signs of raised intracranial pressure, do not do a LP. If the GCS is less than 8 and or deteriorating, or there's focal neurological signs, or the GCS is less than 12 after a seizure lasting more than 10 minutes, you do not do an LP. If the CT or MRI suggests CSF pathway obstruction, you do not do an LP. And if there's clinical evidence of circulatory shock or meningococcal disease, you don't do an LP at the time. Okay. EEG can be helpful, as I've said. So with the, you're thinking, could this be subclinical seizure activity? And if you are thinking that this is subclinical seizure activity, you're going to treat it. And I should have covered that in D, is that seizure is a likely cause as well. And if they're subclinical and you don't have EEG available, you're going to potentially try a dose of lorazepam and maybe even some Keppra to try and reduce that. In your neuroprotection of significant traumatic brain injury, anti-epileptics are also considered. So consider seizures, and if in doubt, treat for them as well. Our patient has increased respiratory rate despite clear chest. He has tachycardic, he's hypotensive, he has a metabolic acidosis with normal electrolytes and glucose with a carboxyhemoglobin of 32. His GCS of 5 with responsive and equal pupils. He has a normal temperature. He has bruising over his shins and erythema over his knuckles and fingers. This is a patient who I tried to make sound like the parents had an inaccurate history, and NAI must be considered and sepsis must be considered for this child. But this child has carbon monoxide poisoning. He has signs of cherry red spot with his knuckles and his fingers being red. The bruises over shins is normal for a 6-year-old, and everything else is relatively normal except for the hypertension, tachycardia, increased respiratory rate from the metabolic acidosis. All right. So that was just an example. Carbon monoxide poisoning is actually one of the hardest to diagnose unless you have immediate access to carboxyhemoglobin, and it can be very vague in the history. So when you're looking at your gas, look at all components on your gas rather than just presuming you need to know the acid-base disturbance, and that's it. Okay. In summary, because I'm over my time already, first lecture of the day and I'm over my time. Summary, coma is a symptom of underlying problem. It is not the diagnosis. It's a medical emergency and you need to follow a structured approach, A, B, C, D, E, F, G, which is don't ever forget glucose at the end there. You need to take in the observations, initiate emergency management to stabilize the patient while you take further history and do further investigations to identify the cause. Make the patient safe, continue to manage them while you come up with a diagnosis. And keep an open mind. Do not get your mind set on one thing. If I'd made that more obvious about an uncertain history, people would have been going down the NAI route. But this is a case of carbon monoxide poisoning, and if you kept your mind closed, you may not have noticed or seen it. So keep an open mind at all times, but consider all aspects of the potential diagnosis. So I'm going to open up the floor to questions. The code on the screen there you need to put into the feedback form to give feedback on this talk. What I would suggest if you're here for the day is just to keep a record of all the codes and put them all in at the same time you do your final feedback form. And that means you can just do it once and get credit for all of the course, all of the talks that you've been to.